It's really cool, everything that they've done. So today we get to have our own little exploration in the galaxy of buprenorphine. And the breakout rooms are going to be fantastic. Please don't sign off at that point, because really, really importantly, we want to hear from you. We want your feedback. We want to learn your thoughts and your perspectives. It's my pleasure to introduce Dr. Laura Brown. She is a double board certified addiction and family medicine physician with 25 years of public health experience in New Mexico. She's taken a deep dive into the world of the New Mexico medication for opioid use disorder situation by starting 4 different buprenorphine naloxone programs in Santa Fe from 2009 to 2013 with the Department of Health here in New Mexico, La Familia Medical Center, the Lifelink, and Santa Fe Recovery Center. I know Laura personally. She's passionate about harm reduction, social justice, and economic justice. Dr. Brown got a Fulbright Award, a Global Scholar Award in 2019 to examine the local opioid use disorder treatment landscape in Porto, Portugal, and in Vancouver, British Columbia, both places that have very progressive policies. She currently works on the federally funded Claro project in her UNM capacity, and she's also on faculty with UNM CASA, starting research examining problematic substance use and chronic pain among people experiencing homelessness and unstable housing in Santa Fe and Albuquerque. Laura, it's my pleasure.
Thanks, Kim. Thanks so much. Should I get started now, or did we want to introduce Dr. Pondy? All right. Hi, everybody. I'm Laura Brown. Thanks so much for such a great introduction, Kim. I appreciate it. Christina, so happy to be here with all of you. So I'm going to share my screen and dive in here. Let's see. And we're going to go play from the slide. How are we doing? Great.
Perfect. Laura.
Okay, great. So 15 minutes is really short for all this material, so I'm going to dive in right now. So I'm going to talk about buprenorphine myths and misconceptions, and follow up with some information about stigma and antidotes to stigma. I suspect that all of you have encountered some, if not all, of these buprenorphine myths and misconceptions in your own work via Southwest CTN, UNM ECHO, or other venues. And so I'm going to read each of my top 20 myths, provide some facts or reality check on those myths, and then for some of them provide sort of a suggested policy change or response. Okay, let's roll here. Okay, so starting here, the number one myth that we all know about and encounter frustratingly frequently: prescribing buprenorphine for opioid use disorder replaces or substitutes one addiction for another. And I promise I'm not going to read each slide, but I am going to read this one. Facts and reality. Addiction, as you all know, is defined as compulsive use of a drug or behavior despite harm or negative consequences. But when you take a prescribed medication to manage a chronic illness, this does not meet this definition. And taking a daily medication to maintain health is not a substance use disorder. I've got my references at the end of these myths. So, and then we think about a possible policy response. Certainly we could consider an improved public health campaign to reduce stigma that's associated with buprenorphine addiction treatment, similar to past HIV campaigns that provided education and challenged myths and misconceptions. Okay. Now, why is this not advancing? Oh dear.
Try clicking directly.
Oh, I got it. Okay, there we go. Sorry about that. Okay, so bupe myth number 2, commitment to abstinence will prevent opioid overdose more than buprenorphine treatment. As we all know, abstinence-based opioid use disorder treatment actually confers a loss of opioid tolerance, which is associated with a significant relapse risk and overdose and death risk. So there's that. Buprenorphine, on the other hand, blocks or limits the effects of illicit opioids, thereby reducing the risk of overdose. Myth number 3, buprenorphine is misused frequently, so prescribers should strictly control access. We just need to acknowledge up front that any medication can be misused. And for those with opioid use disorder, buprenorphine is not a first choice to get high because of its partial opioid agonist effects, which, like we mentioned, limit feelings of euphoria and reward. In fact, buprenorphine misuse is clearly associated with self-medication of opioid withdrawal symptoms, and is also used in, where there's lack of access to medications for opioid use disorder. Myth number 4, prescribing buprenorphine involves more legal liability than prescribing other medications, or will make the DEA target the prescriber or medical practice. Well, I don't really think this is the case anymore. I mean, as with all medications, I feel like the key is quality patient assessment, provider education, and certainly everyone's favorite, good documentation. I would say, as far as a response, I would request that there be parity in how the DEA conducts their visits and audits. I think that they should be visiting prescribers of all controlled substances and not just buprenorphine. Just a suggestion. Okay, bupe myth number 5. Starting to prescribe buprenorphine will lead to a large number of people asking for prescription. Everyone's fear that the hordes will arrive in your clinic. Well, I say great if they want treatment. So that's one thing, but this is not actually, with the expansion of treatment options, MOUD treatment options, I really feel like this is not the case at this time as it was perhaps early after buprenorphine became available. Bupe myth number 6. One must be completely abstinent or have a completely negative urine drug screen to receive a buprenorphine prescription. Fortunately, we've seen an evolution of thought and practice on this, especially as it relates to starting someone on buprenorphine with opioid use disorder who comes in with a urine drug screen positive for benzodiazepines. And it's really important to keep in mind that people do not need to be completely abstinent to be treated with buprenorphine. Certainly, people with opioid use disorder commonly use multiple substances. Buprenorphine can help stabilize and break that cycle of polysubstance use, reducing the need for additional substances. And as the New York City Health Department comments, imperfect abstinence does not eliminate buprenorphine treatment benefits. I like that one. Okay, bupe myth number 6. Oh, excuse me, 7. The ideal length of time for buprenorphine treatment is less than or equal to 6 months. Treatment success means patients will become drug-free, including from bupe and methadone. I would like to think that all of us know by now that treatment with buprenorphine is to be continued as long as it benefits the patient, and whether it's months, years, or a lifetime. As we know, stopping opioid use disorder medication inappropriately or prematurely, even after years of treatment, can be associated with an increased risk of relapse, with overdose and overdose death. And finally, I think we really need to be focusing on treatment success being measured as improvement in quality of life, not medication-free status. All right, here we go. Next slide. Sorry, that was a chunky slide. Another one. Promise this is the last one of the chunky slides. Bupe myth number 8. Outpatient therapy or counseling is mandatory for clinical improvement. This just isn't true. Data 2000 mandated that all bupe providers must be able to refer patients for behavioral health services. But we do know that while therapy or counseling may benefit many patients or some patients, it is not mandatory. And I think we all need to be constantly moving towards a more of a medication first approach and low threshold buprenorphine services. In the past, programs that I have been aware of have mandated participation in intensive outpatient therapy sessions in order to receive a buprenorphine prescription, and this is clearly out of date. Bupe myth number 9. all persons seeking opioid use disorder treatment have equal access. Well, we all know this isn't true. Certainly the BIPOC community and other people with lower incomes have decreased access to treatment. And we also know, conversely, that those with private health insurance that have buprenorphine prescribing restrictions or strings attached in terms of copays and other issues actually may have decreased access to treatment compared to those in states like New Mexico, where Medicaid will cover buprenorphine for opioid use disorder treatment. Certainly a policy response is, I think we need Medicare for all, some sort of single payer national health insurance that covers buprenorphine for all who need it with opioid use disorder. Myth number 12, prescribing buprenorphine is time consuming and burdensome. I think we've covered this well enough. I don't think it has to be this way. I think certainly with the movement towards medication first and low threshold services that don't require in-office buprenorphine inductions as a long time ago, or intensive outpatient program participation, I think that dispels this myth. Myth number 13, reducing opioid prescribing alone will reduce opioid overdose deaths. Well, we've seen increased overdose mortality in spite of decreased opioid prescribing of full opioid agonists, analgesics like OxyContin, et cetera. And so this basically, where are we? Oops, excuse me. I just realized that I skipped one. In fact, I skipped a few, my bad. I'm gonna go back to myth number 10. I'm so sorry. Okay, myth 10, treatment of opioid use disorder with buprenorphine is more dangerous than other chronic disease management. Well, I'm here to tell you as a family medicine physician that titrating insulin for somebody with diabetes is way more difficult and potentially more dangerous than starting somebody on buprenorphine. Enough said. Myth number 11, detoxification for opioid use disorder is effective. There's really no data showing this efficacy of detox, and actually a detox approach is actually risky if it's associated with overdose risk through loss of tolerance. So certainly the policy response on this is super important for us to consider. I really feel strongly that all detox programs, whether they're public, city, state, county, as well as the private sobering centers, et cetera, should all be mandated to provide maintenance buprenorphine and not just buprenorphine for relief of opioid withdrawal symptoms. I already talked about myth number 12. I started to talk about myth number 13. What I was going to say beyond what I already said about reducing opioid prescribing alone is that patients with opioid use disorder that's untreated or inadequately treated may shift to illicit opioids, such as fentanyl, with increased overdose risk. So this is just evidence that reducing opioid prescribing alone is not an effective strategy. Myth number 14, we're almost there. You aren't really in recovery if you're on Suboxone. Well, okay, so total stigma situation. Recovery is not abstinence. Abstinence is not recovery. As we all know, recovery encompasses improvements in quality of life that may involve prescription of chronic disease management, such as opioid use disorder. Myth number 15, it's as easy to overdose on Suboxone as it is to overdose with other opioids. This is a pharmacology education issue as far as buprenorphine being a partial opioid agonist versus the full opioid agonists. Let's see, and more final bupe myths and misconceptions. Myth number 16, Suboxone isn't treatment for addiction if you aren't getting therapy with it. We've already discussed this. Myth number 17, Suboxone use represents a failure of willpower or giving up. As we all know, opioid use disorder is a medical condition or disorder, not a moral failure. Again, more stigma. Myth number 18, use of Suboxone is incompatible with 12-step groups like AA and NA. This is a really important one. more stigma, unfortunately. I think it's improving, but many patients I've worked with over the years who are I'm prescribing their buprenorphine or they're in methadone programs are uncomfortable disclosing this in 12-step meetings at best. Worse, sometimes they are pressured to prematurely discontinue one of these life-saving medications in order to continue group participation. Like I said, I think this is getting better, but it's still a challenge. Myth number 19, patients can get high or loaded on Suboxone. If in someone who's dependent on opioids, they do not get intoxicated with the partial opioid agonist Suboxone, buprenorphine. Intoxication can in fact occur in those who are not opioid dependent, but these are not your patients to whom you're prescribing buprenorphine. So as with all substances, whether they're prescribed or legal or illicit, mixtures of substances can cause intoxication. Although I do think we need to remember the harm reduction aspect of buprenorphine as a partial opiate agonist. And finally, myth number 20, patients will just sell Suboxone. So as we've mentioned, diversion and misuse across the entire spectrum of medications. There was a 2014 article that found similar rates of diversion between buprenorphine and antibiotics at about 20% each. That was 8 years ago. And as I mentioned earlier, the myth number 3, buprenorphine misuse is clearly associated with self-treatment of opioid withdrawal symptoms and is used in cases where MOUD access is lacking. Okay, so here are my references, and so where are we now? Okay.
Sorry to interrupt, Laura. You've just got about a minute and a half left.
Oh no! Oh my gosh. Okay. I'm going to flip through these quickly. All right. Just a reminder of the life-saving benefits of buprenorphine. Oh my goodness. Wanted to talk about stigma beyond language. Here's the slide. I'm going to buzz through. I'm so sorry. Here are some antidotes to stigma beyond language that I would hopefully love to discuss. I'm glad we're going to give out these slides if people are interested.
Take your time here on this a little bit, Laura.
Oh, I thought I had a
Just
minute.
well, I know, but this is important.
Thank you. Appreciate it. Sorry again. We can view antidotes I wanted to talk about. We can view problematic or chaotic substance use as a public health issue and not a moral or criminal one. This is not new. Look at Portugal. They decriminalized all drugs in 2001. We can acknowledge the stigma is fundamentally about fear of the other, fear of the unknown, fear of mental illness, fear of our dark side. We know we need an improved social safety net. And finally, what I wanted to focus on and highlight in my remaining time, we can aim for greater compassion and humility by looking in a mirror to break down an us versus them mentality. Okay, so here we go, mirror, mirror on the wall. And wanted to mention, in 2019, I gave a university talk with my Fulbright work, and I focused on problematic behaviors as well as substances. Here we have some depictions of that. Here we have sugar as a substance. We also have associated with overconsumption. We have on the left, we have gambling, usually associated with problematic use of alcohol, tobacco, other substances, and then driving while impaired. On the right, we see an overweight family watching a screen, eating Cheetos mindlessly perhaps. And here we have digital drugs and screen consumption. And this article on the left came from the Santa Fe New Mexican just this past weekend, really tragic 17-year-old suicide from a self-inflicted gunshot from a 17-year-old girl, a young woman who, after a sexual assault, mental health crisis, and her parents restricted her access to her cell phone and social media. And so it's resulting in a lawsuit against Facebook, TikTok, and Snapchat. Here we have more digital consumption. This is my own screen time on my left, on my cell phone. I'm not so happy about this. More More importantly, we have a woman texting while driving, getting ready to strike 3 pedestrians in the street. Texting while driving, lethal. So in that talk in 2019, and I promise I've got like 2 more slides, I coined this term addiction to excess that we see here in the US with both problematic behaviors and substances. And 2 years later, Dr. Anna Lemke, who some of you may already be familiar with, has written a really great book, Dopamine Nation, and she refers to compulsive self-destructive overconsumption. What's important about this book is that she uses the wisdom of her patients who have been struggling with problematic behaviors and substances to teach us lessons of recovery, which really address their antidotes to the stigma that I feel like this us-them stigma, which is really, I think, a very powerful antidote to stigma. And I really thank you for your attention. I'm so sorry I ran over, and I'm really looking forward to Dr. Pondi's talk. Thanks.
Thanks, Laura. That's a lot of information. I know that there's some great questions and some great comments in the chat, and we're going to have more of an opportunity to talk about those in our breakouts. I really like how this went from, you know, the myths, of which there are many, and these we will have a handout for you to that we'll be sending out to everyone, and our YouTube channel is in the chat. So, you know, buprenorphine, like is kind of, to me, is a little bit like airplanes now. There's a million of them taken off every day, but you only hear about the crashes. There's a lot of people getting a lot of help with buprenorphine. So don't focus on the crashes. It's my pleasure now to introduce Shashwat Pandi. Dr. Pandi is one of 2 triple boarded general, child, and adolescent and addiction psychiatrists in the state of New Mexico. He graduated with his addiction fellowship from the University of Pennsylvania and was in private practice for 2.5 years in Center City, Philadelphia, prior to taking the academic position here at University of New Mexico. We're so lucky, where he's been for the last 2 years. He's currently the medical director of the Substance Use and Treatment for Adolescents and Young Adults in Recovery program, which we call the STAR program at the Addiction and Substance Use Program, or ASAP, at UNM. We're, like I said, super lucky to have him. He has presented nationally at the American Academy of Child and Adolescent Psychiatry meeting, the American Psychiatric Association National Meeting, Indian Health Service National Telemeeting, as well as regionally and locally. He's also currently a medical clinician on the Southwest CTN RDD, and that has a really long name, but it's about retention trial, looking at the efficacy of various medications for opioid use disorder, as well as discontinuation strategies for Suboxone and Vivitrol. We're very, very happy to have Dr. Pandi join us. Thank you.
Thank you, Kim, for such a wonderful introduction, and thank you for having me. It's really a pleasure to be here. So I will share my screen, and I think here it is. Okay. So today I'm going to talk about medications for opioid use disorder among adolescents. And what I really want to do is look at kind of the research and evidence that we have so far for it. We know opioids have been used for about 6,000 years for pain. Hippocrates talked about using it for headaches, coughing, asthma, melancholy. Unfortunately, with the increased potency, it's increased physical and psychological dependence. To give an example, heroin in the 90s was about 6 times stronger than heroin in the 70s. And now we're in the fentanyl age, and fentanyl is 50 to 100 times more potent than morphine. So there's 2 terms that often get used interchangeably, but they are different. One is opiates, which is resin taken from the seed pod of the Asian poppy, and these include opium, morphine, heroin, and codeine, so the derivatives of opium. Then there's synthetic opioids, and that's OxyContin, fentanyl or Demerol, which are synthesized or manufactured. And what we know is that overdose death rates involving opioids have skyrocketed. And right now we are in the fentanyl age of the opioid epidemic. And you can see that almost all the overdoses now are from other synthetic opioids, which are primarily fentanyl. And this is only to 2019 is what the CDC has available, but we know the data from COVID has gotten worse, and there's at least a 30% increase in overdose deaths, primarily from fentanyl. So if you look at why fentanyl is used, these are lethal amounts of heroin, fentanyl, and carfentanil, which is an elephant tranquilizer. And you see the fentanyl is much less than the heroin. And for drug trafficking organizations, the cost of a kilogram in US dollars of heroin is $6,000. And they can sell that at wholesale for about $80,000. The cost of a kilogram to a drug trafficking organization in the US of pure fentanyl is about $41.50. And that makes about 20 kilograms. So whereas they make $80,000 from a kilogram of heroin, they make about $1.6 million from a kilogram of fentanyl. And it's far more addictive. And this is from the DEA website. So this is just a slide from the 1900s. They used to use Mrs. Winslow's soothing syrup, which is actually it was a opiate serum for children's teething, believe it or not. This was before the Harrison Act eliminated opioids in the US in the early 1900s. So if you look to paths to youth opioid use disorder, the vast majority of youth who initiate opioids have problems with other substances first. And most youth who are prescribed medical opioid analgesics do not use them non-medically. There's been plenty of studies that show that if you're adequately treating youth pain with opioids, they will not go on in general to using the opioids non-medically. And while some youth have been prescribed medical opioids before non-medical use, the majority who initiate with non-medical use. So really, there was a great book called The Unbroken Brain by Maya Zlotnik. And this is looking for intervention for youth substance use, really is prevention for youth opioid use disorder, because addiction is a developmental disorder of pediatric onset. So the Unbroken Brain talks about how 90% of people who are diagnosed with substance use disorders are first diagnosed under the age of 25. And that's really when your brain is still myelinating and the white matter tracts are still being laid down, and you don't have that executive functioning as well. And we know that the earlier onset of use is associated with worse outcomes. For example, if you just look at alcohol alone, if your first drink of alcohol is at the age of 13, you've got about a 47% chance of having an alcohol use disorder. But if you can wait until you're 21 years old, your likelihood of having an alcohol use disorder is only 9%. So the same is true with opioids and every other substance that we know of. Earlier intervention is more effective. And opioid addiction is really an advanced stage along a continuum of illness of substance use disorder. Usually people will not start with opioids. They usually progress to them, which is why prevention is key. The three biggest trials on opioid use disorder that were randomized controlled trials, one was the MARSH study, which compared two groups for a 28-day randomized control trial, and it also offered thrice weekly counseling with adolescents and contingency management. And this is what got buprenorphine approved for people as low as 16 years old. And the reason was they found that 64% of the buprenorphine group had negative urine opioid tests compared to 32% of the clonidine detox group. And what was more impressive, the hardest thing with working with adolescents is keeping them engaged in treatment. But at least in this study, even though it was only 4 weeks, 72% of the adolescents stayed in treatment in the buprenorphine group, and only 39% who were still offered the 3 times a week counseling and contingency management. So they were getting rewards for staying in treatment, remained in treatment. The next study that was a CTN study, actually. It was the Woody study, and it was a 12-week randomized controlled trial. And they found that there was less self-reported opioid use during treatment. And it was 8% less. There was less self-reported opioid use during treatment. And if you looked at the end of treatment abstinence while being on buprenorphine versus a 2-week detox, it was 8% better, which was significant. And 70% stayed and were retained in treatment compared to 21% who were just detoxed and just dropped out of treatment and didn't follow up at 12 weeks. And they followed these patients out to a year. And I'll talk about some of the data following them out for a year, because it's actually more impressive data. The next was a study, actually, I think this trial was the Mitchell trial looking at extended release naltrexone or Vivitrol versus treatment as usual. Unfortunately, the Vivitrol, I believe they ended the study early because there was no difference between treatment as usual versus the Vivitrol. It just wasn't, but there is a place for Vivitrol in opioid use disorder for adolescents. You really have to tailor your treatment. But features of youth opioid treatment are basically developmental barriers to treatment engagement. Youth, we say that they feel they're invincible, but that's actually not true. What's true is they estimate risk more accurately than adults. For example, an adult will hear there's a 5% chance they'll get killed if they go outside, and they definitely will not go outside. Whereas an adolescent will say, well, that means there's a 95% chance I'll be okay. There's also the immaturity and lack of executive function because the prefrontal cortex isn't fully myelinated. There's motivation and treatment appeal, and then the salience of burdens of treatment. And there's also the variable effectiveness of family leverage or not. We know that adverse childhood experiences play a large role in why people use opioids in the first place, and just having any sort of abuse or witness to domestic violence or family members with mental illness or who are incarcerated all play a role. And at least there's one study that showed that 67% of the reason why people use drugs IV is because they were exposed to 5 or more adverse childhood experiences compared to those who have been exposed to no adverse childhood experiences. There's also a pushback against sense of parental dependence and restriction. And this is the age where you develop your sense of self. Abstract thinking kicks in. Marketers know this, so everything they target is to the 13 to 25 demographic, because the music you like, the food you like, the clothes you like, the type of movies you like, you're gonna like for life. And then there's a prominence of comorbidity. And what we know is if you look at generally kids without substance abuse, only 14% of them have a comorbid psychiatric issue. But kids with substance abuse diagnosis, 80% of them have a comorbid psychiatric issue, whether it's PTSD, whether it's bipolar disorder, major depression, general anxiety disorder, conduct disorder. So this was the Woody study I was talking about. And what was really kind of amazing was what was not so much the 12-week mark, which showed the 8% gap where people were better. But if you went out a year further, those who stayed on buprenorphine did much better. They did about almost like 25% better than the group that was detoxed. And what we know about just detox alone is that 12% will stay sober in 30 days. 88% will relapse for opioid use disorder, and the risk of overdose is higher, like Dr. Brown says, because they lose their tolerance. And in 90 days, 92% will, in general, relapse, and only 8% will stay sober. So the hardest thing with youth is really retention. And usually by about 60 days, if you just do a detox, almost everybody has dropped out of a study. And 75% will be retained of young adults and adolescents. And after the first clinic visit, 45% stay in at 60 days, and you get 9% retention at a year, which isn't great. For adults, retention rates are usually much higher. Our treatment rates for treating opioid use disorder for adults are just as good as our treatment rates for diabetes, and they're just as good for our treatment rates for hypertension. We have about a 60% success rate, and we have about a 60% retention rate, which is amazing. For adolescents, it's not that great. This study, the average age was 19.2, and predictors of retention were urine drug screen opioids were negative, urine drug screens were buprenorphine positive, and urine drug screens were THC negative. This is just another one comparing older adults versus emerging adults. You can see that only 17% of emerging adults who are 18 to 25 stay in treatment at a year, whereas 45% of those 26 and older do, which is the usual rate for most chronic conditions. And then this is just looking at how it is important to be flexible with kids, because you would think daily attendance would be best for them. But actually what was interesting was this study looked at daily attendance and found that retention was worse with daily attendance. And this was done by Marsh, who did the initial study to get buprenorphine FDA approved for adolescents. But if you do 2 to 3 days per week attendance is better, much better. And the urine drug screens were negative more often. So there's sort of like overly controlling adolescents actually backfired, which was interesting. This is just some studies looking at Vivitrol. This was a case report. The Marshall study was never published because it was a negative trial, but this case report found that 20 youth received extended release naltrexone, 16 initiated outpatient treatment, 10 were retained at 4 months, and 9 had a good outcome. The study for extended release naltrexone was actually done in Russia because they don't allow medications for opioid use disorder. So all they have is Vivitrol, and it was done with very highly motivated young males, and they found a 36% success rate compared to 23% with placebo. So there was a 13% benefit, but that's nothing compared to the 60% we get for buprenorphine. But like I said, you got to tailor the treatment to the individual. This was a Johns Hopkins case series. They were able to get better success rates by actually going out and doing home doses of extended release naltrexone with an ACT-like team for young adults who had opioid use disorder. So basically, the summary, the evidence we have so far, our medications are feasible and effective, and buprenorphine is definitely better than no buprenorphine, because overdose is, especially in the fentanyl age, is a huge risk. Longer buprenorphine is better than shorter buprenorphine. Residential with and without meds is effective as one component of a continuum, but then you have to, like Dr. Brown said, you have to have care afterwards. Extended release naltrexone is promising in some studies, but it's still not the standard of care. Buprenorphine is standard of care. Retention continues to be problematic, and initial exploration of moderators and mediators include early adherence and success, other substances, especially marijuana, and concurrent psychiatric treatment. So elements of a recommended treatment model include emphasis on ongoing engagement from detox to next levels of care. The revolving door should lead somewhere, specialty care, longitudinal follow-up and management, integration of relapse prevention medication as the standard of care, whether it's buprenorphine or extended release naltrexone, counseling and mutual help, and co-occurring dual diagnosis treatment for comorbid psychiatric issues. I would add to that medical treatment too. I know with fentanyl, most of the pills are smoked in the Southwest, but just doing a Hep C treatment and HIV treatment is important. And then when people talk about residential inpatient treatment, detoxification, withdrawal management, crisis stabilization, it's an assurance of temporary abstinence, but it's a role induction for the next step of treatment. And detox and residential stay is not a cure. It's the first battle in a long war. And then we have to focus on engagement and transition into outpatient treatment. And you can occasionally do readmissions to booster if you see relapse that can't be managed as an outpatient. And that's pretty much what I got. Thank you for your attention.
Thank you, Dr. Pondy. We are going to randomly put you guys into some rooms so that you can chat in some small groups about this. Those were both wonderful presentations, and I'm turning the controls over of the spaceship to Christina.
And so one of the things she said is what's important moving forward? How can the node and these kinds of discussions be most beneficial to you? And one of the things that Donald brought up is the fact that, I mean, I work at the STAR program with Dr. Pondy, and even like 3 years ago, fentanyl was this thing that came around on occasion, and now it's like everything we see. I mean, we're so excited when we get somebody who just overuses their Oxycontin. It feels like a gift, right? I mean, I'm being facetious, but it's, we got 12-year-olds that are hooked on fentanyl. It can get pretty overwhelming. And so really understanding how to use buprenorphine, particularly with some of the newer synthetics, and recognizing, in part because of what Dr. Pondy said, why for the people who supply these drugs, things like fentanyl are so appealing. They're just such bigger moneymakers. And then we had some really nice discussion about the fact that with youth in particular, how do we engage them earlier? How do we keep them engaged? How do we fight back against that sort of dopaminergic rush that everything is offering them? And then Michelle brought up, I think, something that resonated with all of us, which is how do we just address, and actually Rafaela too, what are the social determinants of addiction and social determinants of psychopathology, and how do we get it? It's a big task, but how do we get at the root of that? Buprenorphine's great, but that's on the tail end of the addiction issue. And how do we move a little farther upstream? So did I miss anything, you guys?
You did good, Virginia. Thank you.
Wow, great. Thank you so much, Virginia. Anyone else? Would anyone else like to share what you discussed in your group?
Our,
Oh, go ahead.
okay. Our group had a lot of experience dealing with the stigma that comes with OUD and MOUD. We had a couple of community support workers and research and everything. And we discussed how the stigma comes at every level. There's stigma for use. There's stigma for needing medication. There's stigma sent at the providers who are willing to prescribe it. There's stigma from the community about any efforts that are even attempted to help people with these issues. And it sort of comes, we decided, a bit from a lack of education about what people with these opiate use disorder problems are experiencing and dealing with, and also from the lack of understanding in the community about where the resources are if you need the help. But we all agreed that something that we looked forward to information from was about what community support there is that we can direct people to or offer, as the case may be.
I would just add to that, Fletcher, that one of our participants is in a new program that's focusing on youth, and that's really important. And then another participant is with an emergency services program that was really brand new. And so it's great to hear about these new initiatives because this reaches every part of our society.
Thank you, Fletcher. I think we have time to have maybe one more group share what was discussed, and then we can move on to questions and comments for our panelists.
Hi, this is Andy Shee from Group 1. And I think our group was particularly interesting because we had folks from Farmington, Gallup, and Lee County and Santa Fe who are part of treatment programs, and they're really in a quest for more information about medication treatment for opioid use disorders. They're seeing folks with fairly significant opioid use and are, I think, identifying issues related to information, education, and availability of providers in their communities. And so I think that's a big need. We didn't touch on telehealth models when we spoke about that, and we also didn't talk about some of the drivers for use in the communities. But I think that was a big set of issues that we identified.
Thank you, Andy. Very important. All right. So now we can move into if anyone has questions that they'd like to ask our wonderful presenters, Dr. Brown or Dr. Pondy.
Alicia here from the Mountain Center. I just wanted to say your presentations were awesome. I might even use a few on my presentation as a trainer. I really appreciate everything you guys do. This helps me get better at what I do. So thanks.
Well, thank you all for being here. We really appreciate it. And
Thanks, Alicia. Glad to continue the conversation with you anytime.
yeah, same here.
That's one thing about this wonderful community. If you need to reach out to anyone here, you will get a response. So don't feel free. If you feel shy about asking a question today, do reach out to any of our panelists or to me and Christina, and we'll send you in the right direction. This is your opportunity to ask some great questions, please.
Hi, this is Andy Shee. I have a question for our panelists, and it has to do with concerns about the initiation of Suboxone or buprenorphine treatment in incarceration facilities. And I wondered what your your work and your experiences are like working with those populations.
I can speak to this. Shashwat, did you want to start or?
Sure. I mean, I know Dr. Romo was part of an effort to make both methadone and Suboxone available throughout the incarcerated population in New Mexico, and they've had really good results with it in terms of keeping people in recovery and getting people back to having better functional outcomes, both while incarcerated and after leaving incarceration, and then continuing with treatment. And we actually do part of a diversion program at ASAP where for our adults, we have people who come in and get involved in recovery and the resources, and they get linked up to both medical care as well as psychiatric care too. So.
Andy, I would say also, I've been in Santa Fe a long time since I did my residency here, and I've seen the situation change over time. I was involved in public health outreach, and when at a time in the early 2000s when buprenorphine was allowed in the Santa Fe Detention Center, and then it's not allowed, and there's been a lot of controversy and challenge around that. I was on the Health Policy and Planning Commission in Santa Fe County, and promoted this concept of the provision of MOUD in all correctional facilities. I've been involved with this issue for years. Happy to keep talking about this.
And thanks. Just to follow on, I was particularly talking about youth facilities.
Oh, youth facilities.
And,
okay.
And just wondered kind of what it looks like in your work.
You know, that is actually a really good question. I don't know about juvenile justice. Dr. Brown, do you know about juvenile justice and the availability of medications for opioid use disorder?
I'm sorry, I don't have detail. I will tell you there was an incident, a very tragic incident where the provision of naloxone wasn't even available at the youth detention facility here in town a few years ago, resulting in a very tragic outcome. So I think there's a lot of work to be done, in my opinion.
That's good to hear. Yeah, that's great. Phil?
I know the Bernalillo County Youth Detention Center will put youth on Suboxone while they're in detention if needed. So, and we have had luck with when they transition to our treatment program, they will give us a script for 30 days, which is really nice. And then it gives us time to find them a provider in the community.
Since we have a couple minutes left, we have two hands raised. First is Miles Bonney, and then Phil Feudy.
I'd like to divert to Phil, but I won't waste time. Real quickly, I guess I'll say that this is a lot of factual, high-level data, and I do my best to try to gather what I can and bring it to a level that I can include it within my prevention initiatives within TAUS. I'm wondering whether this sort of factual latest information can be culled and mutated into some sort of educational presentations for those who do serve the schools, because I think there's a huge gap in that, and it's often filled by commercial interests that don't necessarily have the same sort of perspective and clarity. And I just like to put that out there as an encouragement for the state, whether it's the UNM or otherwise, to consider taking these great minds and information and simplifying it so we can then also justify, hey, this is from blank in the state. You can't be against that. It'll help with us as we navigate law enforcement approaches, health prevention, et cetera, or health promotion, et cetera.
Miles, that's a wonderful suggestion. And I will say two things. One, we're going to write this down and do our best, and we'll send some stuff to you to help us design those. But two, do reach out to us, because I know that I and many of the folks that we work with here are happy to come up to Taos and just do a real one-on-one intimate discussion about any of this too with you and your colleagues. So the Southwest Clinical Trials Network is really aimed at getting evidence into practice. So if you have a practice and you want more information, reach out to us and we'll make sure that we reach back to you.
Okay, thank you.
You're on the hook now, Miles.
Thank you very much, Miles. Very good suggestion. We'll love to follow up with you about that. Phil.
Hi, and thanks for that, you guys. It was really great. And mine, just a request actually. If you're going to share the materials and stuff afterwards, any resources that we could potentially access for youth would be phenomenal. I was sharing in our breakout that we had a client here last year that we were trying to help, a 17-year-old who was chronically overdosing, and it was a 6-week wait to get in the program and blah, blah, blah. And we weren't successful with that. And then in recent months, I've been on 2 large email chains trying to find assistance for a 13-year-old and then another one who was 14 years old. And the solutions were horrible for the guardians or whoever, like,
Or non-existent.
do that. And so it sounds like there's things happening, but if you have some numbers and names that you can include when you send that out, it would be so appreciated, because I think this is just going to keep getting bigger and bigger. That's what we're experiencing up here anyways. So
Thanks, Phil.
All right, we're at time. We've got a couple more questions, it looks like, trickling in. So for everyone who needs to jump off now, thank you so much for joining. We will be sending out the resources from today's session, including the recording, out to you all. And Noreen Kelly, I believe, had raised her hand. If you'd like to go ahead.
Yes, good afternoon. Just listening about the challenges of schools, and I have a school in my community which I serve on as a board, is a Bureau of Indian Education. So I'm thinking, how are we going to be able to even use the, should we or the doctors come up with like a teaching tool, like someone had asked, how that would be a challenge for me to share with our school, because it doesn't matter where a child comes from, they're going to be exposed to what we're talking about, and they're going to need services. I've been so focused on adults that I've really left the young children, the young people behind, and I need to refocus my attention. Thank you so much.
Thank you, Noreen. All right, I'm trying to be mindful of the time. If we want to go another couple minutes, that's fine with me. Kim, what do you think?
Yeah, I want to be respectful of everyone's time, but we're happy to entertain more questions. And remember, you can always reach out to us too, because we want to hold these sessions to address your questions, and the ideas that we're getting from you today will feed another session next month or the month after. Next.
I believe Laura, and then Donald Hume.
Thanks so much. I'll be brief. A couple quick thoughts. In terms of like more adult adolescent treatment facilities, we need to be thinking about opioid settlement monies that are coming into the state in terms of accessing treatment resources in our quest to provide better treatment for adolescents, which is severely lacking, as we're already hearing. That's one issue. And the other quick issue to consider is schools adopting, as some are around the state already, the Drug Policy Alliance Safety First curriculum, which is an evidence-based curriculum that I think is solid. So just those 2 suggestions. Thanks for this rich discussion. Really appreciate it.
Thank you so much, Laura. Okay, Donald Hume.
Yeah, I was just wondering, are there trials being done right now on the long-acting buprenorphine for adolescents? And if there is it being done? What age group are they doing it with?
So that has actually been what I've wanted to be involved with for the last 2 years, but there are no trials that are on the horizon right now because it's a game changer if you just give someone a shot and then 4 weeks. My hunch is, because we use it all the time in our adolescent addiction clinic for kids who are non-compliant or kids who have problems with retention, and it works so much better. So I'd love to see some evidence that it actually does that, but I just, there haven't been any trials lately. So.
Joshua, please submit a concept sheet to us and we'll propose it to the CTN. I'm sure you're not alone in wanting to do this.
That would be great.
Maybe we could have a back channel conversation with you. Oh, I'm sorry, Donald. I was going
to say, to be able to get somebody off for a solid 30 days and then give them another 30 days is game changing.
Yeah, no, that's what I've seen. And, you know, my colleagues who do the adolescent work have seen the same thing, where it's completely different, because the hardest thing with the kids is keeping them retained. And if you know that they're covered for 28 days, it just changes everything. So.
Yeah.
Yeah, thanks, Kim, for offering. That's really helpful.
I put the Safety First link in the chat. There's materials in multiple languages that Dr. Brown mentioned. So feel free to access that.
All right.
And I think we'll close it up.
Yep, we'll close it up there. Thank you so much, everyone. I put the email to reach us at the Southwest CTN. If you'd like to reach me or Kim, feel free to send us an email. And we look forward to continuing the conversation. And thank you for all of your feedback. As Kim mentioned, we'll be using that to develop additional events in the near future.
We have in the pipeline. We're going to do something on Kratom.
Kratom.
Yep, Kratom. I don't know how to pronounce it. And there's some other things that we have. Christina, what were they?
Gosh, Kratom. And then we're going to be continuing this series that we're doing on medications for opioid use disorder and various angles around that and perspectives and things to focus on. So,
and the language of addiction, the language that Dr. Brown talked about today, and how we address and talk about this, which fuels or helps to reduce stigma. We're going to have a whole session on the language of addiction. So we'll hope to see you again in the future. Thank you all.